I'm one of around 70 to 80 geriatricians in the whole state, which is shameful. I think that it's insane that, we have probably thousands of pediatricians and yet only 70 to 80 doctors that are specialized in taking care of older adults as they age and their specific needs. Part of that is, of course, memory. I myself do clinical care, but I also do a lot of memory care. I do specialty memory visits that you can ask your primary care to refer you for if you are concerned about some of these issues and if you want to be evaluated. I love those visits. It's funny to say that I really like dementia in certain ways, but it's because I really like the people with dementia a lot, and the patients, and of course the wonderful caregivers. I hate it as a disease, just like, somebody that treats cancer doesn't love cancer, and it's very similar in many ways. We're talking an incurable illness. And so of course it just strikes terror in the hearts of every older adult as they age. They wonder, okay, my mom had this, or my grandma, or somebody else, is this going to happen to me? And that's a very real fear. And I hope through this talk that we can talk about that and we can go through what those concerns are, whether they're warranted, and how to get evaluated, and all those things. There's so much misunderstanding and misinformation about dementia, and it's an evolving science. That's something that is brutally clear to the people that care about this topic, how many gaps we have, how many things we have to know or want to know about the disease that we don't. So keep that in mind. I'm going to share statistics in this presentation. Just know that there's a lot of variation, a lot of individual, factors and other things. So don't come out of it hopefully feeling too depressed about what I'm saying. I know we're talking about a very heavy topic, but I hope that it will be more positive than that. That is something that I always try to instill in my patients. So let's get started. So just to begin, it's very important to understand normal aging changes in the brain versus a dementia. There are a lot of mimics between the two, and I get a lot of questions in my clinic, just with my primary care patients, whenever they notice anything is different. Is this coming for me? And so it's really important to understand the differences between those and what makes them distinct. So I put on their age dependent, but not a normal part of aging. How often people get this is dependent on age, but it's not the only factor, and it is not a normal part of aging. So it's not, guaranteed to happen by any means. But we need to talk about what normal aging is and what is an actual disease. Okay, so let's start with normal aging. I think everybody in this crowd, myself included, kind of understands normal aging and what comes with it. We have that term in the public conscious senior moment, which notice that they say senior moment, not senior days, weeks, months. That's kind of what we're talking about here. So the key with normal aging is that it does not affect your functioning. Very important. And I ask a lot of questions about functioning as part of the history that we take. But understand that there are declines that happen with natural aging. We can't expect to be quite as sharp and as clear as when you're 20 or 30 years old. Youth is wasted on the young, as they say. You have all this wisdom and knowledge and experience, and yet it's going to, there are going to be changes that come with it. And there's, again, variation on the amount, but it's around 10% decline per decade in certain functions, especially the learning and recall. That is, again, it's very dependent on the person, but, nobody is going to, as they age, be entirely the same as they were when they were younger. So just kind of understand that that is going to happen. So what to expect with normal aging? So speed decreases. I think everybody in this room has probably experienced where you're taking longer to process and to recall something, but then, a minute later, you're like, oh yeah, that's right. That's that guy's name. That's where I went. That is a normal process, okay? Forgetting names, but remembering later, I hear that all the time. It scares people to death, especially when it is a loved one. When somebody forgets the name of a beloved grandchild, that one time, that they haven't seen in 6 months, that bothers them a lot. But you think, again, this isn't somebody that they're seeing every single day. That's, it's not really entrenched in that memory. And so that might be excusable if it's just, again, that moment, that one time. Losing things from time to time, but able to retrace steps. Everybody's going to forget where they park. Everybody's going to forget where they put the remote control. Everybody's going to forget, why did I walk in this room? Oh, what was I doing? Oh, what was I supposed to do after this? Those are normal changes. Trouble finding the right word occasionally, that's another thing that I get a lot of complaints about, and people tell me, they say, I used to be so good with words. And now I just, I'm having trouble finding the right word. And when you talk about it, it's just like, that one time or something. I was at church and I was trying to remember that Bible passage and, this sort of thing. Making a bad decision once in a while. That's life. Everybody's going to make a bad decision, but we're going to go into when it becomes a problem. Occasional financial errors, trouble with math, trouble with, figures, things like this. The key is at the bottom there, you can still learn new information. And this is something that we actually test in the memory clinic is recall with prompting. So whenever I test somebody on this one factor, we do a lot of repetition. And I say, okay, I want you to memorize this. Let's repeat this. And that can distinguish then somebody that's capable of learning versus somebody that cannot. All right, so memory loss with aging is very common, but it is never a normal thing. And notice I say memory loss, okay? Not memory skips or changes or, it took me longer, but actually losing memory is never really normal, okay? So what does that kind of look like? And I made this table, this year, because I wanted to talk about, especially so that you had reference to it, the different domains of functioning, what might change for you. So you can kind of tell normal aging versus dementia and what you need to look for. So there is some qualifying factors between these two things. But notice that kind of milder, occasional things on the left versus very consistent, more severe things that are happening very regularly. So whenever I hear from, because it's going to come from a family member, not from the person that I'm talking to, but whenever I hear that they keep repeating the same question over and over again, that tells me that there's a problem with learning. They're having trouble processing and making new memories. Unable to retrace steps versus able to retrace steps. Trouble with conversations versus just finding the right word occasionally. Poor decisions regularly, and trust me, it's always a fascinating conversation when we talk about some of these poor decisions that people start making. Poor financial decisions, that's a whole nother talk, but financial fraud towards seniors, people calling and pretending to be a daughter or a son, and they are preying off of people that don't have the ability to distinguish one from the other. So they might, I had a patient not too long ago who sent about, I think it was like $10,000 to $20,000 overseas. There's been even larger amounts of money than that when I talk to the sheriff's department. So keep in mind, these are really serious. This could affect somebody's ability to live in the long term. I mean, they're on Social Security, which is never enough, and these sorts of things. So just try to understand that these things can be normal starting out, but then when they progress and get more noticeable, it's worth getting evaluated. And that's kind of my big statement, it's always worth getting evaluated. Other things that are not part of normal aging. So decline in planning and organization, getting lost, changes in language, we kind of talked about some of those, but especially the personality changes. I've had people that were just the mildest mannered people that suddenly start doing some wild and crazy things. And then I have the other side where I've had people that are very domineering people, and then they turn very mild and very meek, and they kind of turn inward. These are all things that we worry about. Changes in eating habits is something that we screen for. It can be a safety issue and a health issue. Everybody knows that as you age, you're going to become a little bit more frail. So if you start losing weight too quickly, What's contributing to that there? And changes in hygiene, that's something that can be very embarrassing for people to come forward about, but it's very important. I've had, like Marine veterans that are, they shaved every day, they kept the crew cut, they were just impeccable with their hygiene and grooming. And then suddenly when he stopped shaving, there is something wrong. And the wife is like, oh, I know this because of, look, he used to be immaculate with that. But keep in mind, one thing to rule out is depression. So unfortunately, depression in older adults is often under-recognized. There are a lot of symptoms of depression in an older adult that might look like a dementia, but really they're just depressed. And when we find that, that's a great thing because we can treat that. So that's something to definitely rule out. So before you actually get to a dementia, there's this period of time, and we don't know how long it is. Again, the studies are so poor about how long these things are, but it's called mild cognitive impairment. There's a lot of people that have had an objective change in their cognition, but it still hasn't really impacted those activities of living yet. I've had like people that were very professional people that said, well, I had to stop working. I just couldn't keep up with it. Or I used to be really good at this computer and now I can't use it. Now that person can still drive a car, they can do their finances, they can get themselves dressed, they can do all those things, but there's a change there. And that precedes a dementia, sometimes by years. And there is a certain amount of people that will never truly have an actual dementia. Others, though, will convert over to a dementia over time. And that's kind of that group that we want to find. And I'm going to go through some of the diagnostics and some of the really exciting things in the world of Alzheimer's especially, where we can now kind of predict this when somebody's going to convert over. It's not 100%, but it's much better than we used to do. Because we used to just say, well, I'll see you in a year and we'll see if there's changes. And that's about the best we could do. Now we actually have some ways of testing for it. So that's why I put at the bottom there, it needs reassessment and monitoring. We don't know when that biology is going to change, when that person's brain is going to change into a dementia. So it's really important to constantly kind of get that reevaluation. So I always let patients know and their families, if something changes sooner than when we're scheduled, let me know so we can get you evaluated right away. So, all right. So what's dementia? It is kind of a rough term, and it scares a lot of people, and for good reason. But dementia is a very broad term. Okay, it's kind of a negative Latin root there, or it comes from this word, demens, I guess you would say, which means without mind. So literally it means not having a mind. And so even for hundreds and probably thousands of years, we knew that this was something that affected older adults. There's question about how often it was, or environmental exposures and all this other stuff that might make it more common now. But we know that at least in some ways it existed probably for as long as human beings have been around. And it's still a difficult term though for a lot of people. I try to, especially with certain patients, avoid the word dementia as much as possible. Of course, when I'm diagnosing them, I have to tell them what they have, but sometimes we'll say, cognitive illness, or, these sorts of things to kind of soften it because it is such a scary term. But that is what it means, and it's an umbrella. So when I talk about umbrella, everybody knows Alzheimer's. And I've been asked many times, what makes Alzheimer's different from dementia? Alzheimer's is a type of dementia. And in fact, as our diagnostics get better, we are chipping away at that word Alzheimer's, at that disease of Alzheimer's. We are finding more and more less common forms of memory illness than we used to, just because of our diagnostics have gotten better. It used to be, if you had any of the dementia symptoms, they'd just say, oh, it's Alzheimer's. Yep, there it is. But just understand, it's an umbrella. There are many kinds of dementia. I've had some very rare forms, even in our little small practice there. And oftentimes I'll have to send them to Vanderbilt or something else. We'll have to do neuropsychological testing. just because of not everybody fits into these boxes. And one other thing that's important to understand is there is a lot of overlap in these. So honestly, there's very few patients, maybe very young patients, but outside of that, there's very few people that are a pure Alzheimer's, let's say. A lot of them have some vascular components and some other things in there. And so this is where, the diagnostic part is important, because of course this affects how we treat you. But that's kind of what I want you to get from the slide, is just that there are many kinds. And of course, today I'm mostly going to talk about Alzheimer's, because it's kind of our basic kind of form of dementia that helps us understand the others. But these others can be very difficult. They're rare, but they have a different prognosis, and this is again why it's very important to diagnose it. So again, I wanted to put up kind of the percentages, and notice how much it varies. That's the issue with these studies, is that there's so much overlap with them that you can't really be 100% sure sometimes. So I tell people well, it's most likely in Alzheimer's, or most likely a vascular dementia, but we often don't know 100%. And then there is, I'm always happy to find them, there is a certain group of people that sometimes has another health issue that is mimicking dementia, and then we can treat that. So just, those are the big types though. So medical definition of dementia, I won't spend too much on this or else you'd be falling asleep. But different domains of cognitive deficits, more than one of these has to be required. Usually, especially with Alzheimer's, it does start with memory. But then language, judgment, all these coordination issues, the motor tasks are usually the last to go, and we're going to talk about that. That's why you'll see people at nursing homes sometimes that are completely active. They're walking around, they might not know where they're going or why, but they're still, trucking along there. So the key is that deficits are severe enough to cause significant decline in functioning, and this is important, it requires a decline from previous functional ability. So this is why it's really important to know from a loved one, a family member, they used to be so good at this thing, and now they're not, or some history like that. There are people that come to me and they say, well, I was never good at math, or I was never that good at this thing. And of course I don't expect them to suddenly be good at math. That's just who they are. So it has to be a decline. So Alzheimer's is a chronic progressive disorder. It involves the death of brain cells. If you could look through your loved one's eyes and see the damage that is happening in their brain, it would be astounding to you. But there is a lot of death of brain cells. And thankfully, we are just so beautifully made that we have all this, billions of neurons in our brain. And so we get along pretty well, Even when this process starts, and we'll talk about that a little bit later, it takes a while for you actually to notice a major change. But once that process starts, and once you see, okay, now this is degrading, that's really what is going on, is that there is a loss of brain cells. It has to affect, typically Alzheimer's especially affects memory. That's kind of how it shows up for most people. And then one other domain of cognition. It first kind of starts in those memory centers in the brain, but ultimately, and this is what I wanted to emphasize, it does affect every aspect of that person's health. So it's not just one thing, it affects everything that they're going through. So average age of onset is still about the mid-70s. I think we're finding that this is probably not totally accurate. I think if we went back to the earliest of early, if we were testing people right as they were getting symptoms, it would probably start a little bit earlier than that for most people. But it of course gets more common as you age. The risk kind of goes up from there. 2/3 are women. Again, I think this is something that is affected both by the lifespan of men, but also how willing they are to get tested, and these sorts of things. There's some other issues that I think affect that, but they hypothesize that it's probably due to these kind of differences in women as well. Duration of illness. This is a hard one. I usually try to let people know up front that the average is about 7 years. that from diagnosis till death. But again, we're all hoping that with good intervention and treatment, that could be extended. And this varies so much, even in my own family. So my grandmother, she lived 15 years from her diagnosis till death. I was 15 years old when she was diagnosed. I remember because she was going to pick me up from my marching band practice, and she didn't show up. And then we're like, oh, well, that's strange. And then that started a process by which she then was ultimately diagnosed with Alzheimer's. But she lived then almost to my wedding, which was when I was 30. She passed just before that. But you see, that's a long time, 15 years, but she didn't have any other health issues. She was a very healthy woman. She was a little bit younger, so that really did affect her longevity there. My uncle, however, he's about 4 years in now, and he is in a veterans facility. He's very advanced. We questioned how long he had symptoms before he ultimately was tested, because he probably hid them for a while. And my aunt is like, yeah, he was hiding all this. But still, he's only 4 years in that we know. So you see how that number changes so much, even in my own genetics there, even with my own family. So you might have heard this statement from your loved one, because very often people with an Alzheimer's or a related dementia have very poor insight into what's actually happening with them. So it might just be a comment about, something's not right, I'm getting really frustrated, there's just, this is much more difficult than it used to be. And that's really when your antenna needs to go up and say, oh, wow, I need to probably keep an eye on this, because there might actually be something happening to how they're doing. But those are all comments that I've heard, of course. So let's talk about Alzheimer's a little bit. So Dr. Alzheimer was a real person, Alois Alzheimer. He was a German physician around the turn of the 19th century. He was one of those guys that was an anatomist more than anything. He studied human brains. That's what he studied. And so he met a patient who's on the left there. Her name is Auguste Dieter. She's now kind of written in history as the first Alzheimer's patient. And I know I'm putting quotes around that because clearly it's been going on probably forever to some degree. But what's unique about her is she died when she was in her late 50s. Now notice that I say late 50s because they used to think, oh, well, this is just an age disease. This is just hardening of the arteries. Oh, of course she's getting, senile. I hate that term senile, by the way, because I think it's very pejorative. But they used to say these things as just normal aging. And it took a woman as young as her, with as bad her symptoms were. She reportedly thought that her husband was cheating on her and did all these crazy out of the world things. And she ended up in a mental institution. So that's actually where he met her. She unfortunately died very young from what would now be probably a preventable bed sore, hopefully, but she had clearly progressed so quickly through it. And I put this quote down here because I think it really captures kind of the idea of what he was kind of stepping into. And just so you know, Dr. Alzheimer, his paper did not go over very well. Nobody really cared. They're like, why are you studying an old person? It was just like, and that's still our mentality that we run across, is that there's this age bias with it. Why would we study and treat Alzheimer's disease if it affects people that are retired? Just put them in Shady Pines, whatever. It's so heartbreaking for me as somebody who wants for everybody to be as independent as possible for as long as possible, and to take care of these people and help them have not only quantity of life but quality of life. That was kind of the mentality, and it's been that way for hundreds of years. And I don't know how long it's going to take to change, but I hope it does. It's going to take a lot more than just our little clinic to do it. I heard a really good doctor who said it needs to become a business in America before we'll actually get a cure. And I thought that was so true. We have all these cancer centers. Why don't we have dementia centers? Why don't we have these centers of excellence with these things? And we do at some major universities, but they're not accessible for a lot of people. And there's very few people that are actually interested in these things, as you know. So it took a younger woman to say that something was wrong. And he said, after she dies, please send me her brain. And that was where he kind of established the pathology of Alzheimer's. And so that's why they named it after him. So what is that pathology? And I won't spend a long time, don't worry, it's not science class, but I want you to understand that there are, with Alzheimer's disease specifically, we now understand that there are plaques and proteins that are involved. And these are the target for many of our therapies now, which is exciting. But what happens essentially is that there's a misfolded protein. You know, proteins are these beautiful three-dimensional shapes. And in the brain, this protein then gets cut by these enzymes, and it kind of folds in a bad way and forms these plaques. You can imagine it as like kind of like a chewing gum on the brain or something like that. When you look at somebody's brain with an advanced Alzheimer's, you might even visibly see some of that plaque and protein on there. That's how bad it can be. But this essentially can kind of strangle out the neurons, if you think of it that way. So kind of affects the metabolism of the brain cells and then starts this process by which they start dying. There's also, again, these are all hypothesized, but there's also an idea of these neurofibrillary tingles that then impact brain health and cause these diseased neurons that then start dying off. So that's another target for therapy. If you notice, they mentioned tau proteins over there. That's something I'll be talking about a little bit later as one of our targets for therapy. That's exciting. But what ends up is that you have brain changes, and these are visible. For a long time, they knew that an older adult's brain sometimes would be very shrunken, very big changes throughout. So how do you think we used to be able to diagnose an Alzheimer's definitively? Anybody know? Autopsy. That was the only way to really definitively diagnose these things. So dementia's been a clinical diagnosis for a long time, but so we would have to actually look, wow, this person died from this strange thing. Let's look at their brain. And this is kind of what we would see. A lot of change in the white matter, a lot of change in the blood vessels, and of course, plaques and proteins that now we can test for much better. So, and you can see the areas of the brain there that are affected. So, like I said, long before somebody actually has disease, there might be these changes in the brain that start. And this is really the target of the most exciting research that we have, is the preclinical stage, as we call it, where somebody has the makings for an Alzheimer's, but maybe has not progressed into an Alzheimer's yet. But this is a good idea of the trajectory with this image. But you see how it says in preclinical kind of silent phase. And I love that term, silent phase, because this person might be getting along great, and they might be getting these plaques and proteins that are forming in the brain and things happening, and you wouldn't know. You just think, oh, well, yeah, she's just aging normally. Yeah, everything's fine. So individual may notice changes before anybody else. Now, whether they share that with you is up to them. Because I know my uncle, he put Post-it notes on everything, so they try to hide it sometimes. But oftentimes the person with the disease will notice. And that's where you might hear those comments, I'm losing my mind, these sorts of things, or frustration. So it says the patient knows, but the doctor doesn't, and that's because we can't even test for it, really. Well, I should say we couldn't test for it before. With our cognitive testing, we could not tell. This person would score totally normal. And it's like, okay, well, you're normal, go on, live your life. I'll see you in a year or whatever it happens to be. But then you get these changes, biocognitive impairment, and then you see dementia. That's not exactly an exact timeline or anything. It really does have this effect where it starts out very slow and then you kind of pick up speed, and the changes happen very drastically later on. Okay? All right. So how do we test for dementia? And I won't bore you about the details of these. Just understand that even primary care should, and keyword should, be trained in at least basic screening tests. So the mini-cog is a requirement of every Medicare annual wellness visit. That's, where you draw the clock, you do the 3 words. It only tests 2 domains of cognition, okay? They consider them the most sensitive because, if you are forgetting those words, that's okay. We need further information there, but it's only 2 areas. And similarly with memory impairment screen. Now, we have kind of more detailed evaluation. These are things that we can do in the clinic. I'm always happy when somebody, is very entrepreneurial and wants to do one of them from a primary care setting too, but it needs to be a trained person, because sometimes it's not a good test. If you don't have somebody who's trained in doing it, they might tell you, oh, wow, you scored this, you're definitely, dementia, and you've got all the, and they can probably scare you to death. Whereas there are other factors maybe going on. So that's why you need to know how to interpret it. We use pretty much the bottom three. The top one, the mini mental, is actually a proprietary test. So we usually don't use that outside of research, but it is kind of the standard. Usually it's a combination of MoCA and the Rudos and things. And I won't go into those, but just understand that there's a lot of tests that we can do. I try very hard to keep the testing as little as possible because it's exhausting for a lot of people and for me as well. So it's good to keep it down to a minimal. One thing that we offer now in our clinic, which is us and the Pat Summit Clinic actually both use this computerized testing, is called the CogniView. This is a pretty new device. We've had it for a little over 1 year now. It's been out only a couple years, but what I like about it is that it removes me from the equation. So even though I try not to be biased, of course I'm seeing and hearing what I'm seeing and hearing, and this is actually a computer test that takes the operator out of the picture. So it's a really good way to kind of test different domains. It looks at 4 major cognitive domains. Like it says, 130,000 data points. That's off their website, so I don't know. Anyways, but it's a really good test. There's a lot of cutting edge things that we are now able to do beyond just pen and paper testing. All right, so I get a lot of questions about, do I need to see a neuropsychologist? And the question is, the answer is it depends. And it depends on whether you fall neatly into one of those boxes or not. We talked about dementia and how overlapping it is. And if it's might make a difference in that person's care, I might say, yeah, you might want to do that. But just understand that it is very pricey, unfortunately. It's very limited. You have to go to a very specialized person who can do this. And it's difficult because it takes, on average, 4 to 8 hours of testing to really, and trust me, I've taken a lot of medical board exams and I know what a 4 and 8 hour test looks like. It is not a pleasant thing to go through, especially when you're an older adult with the dementia. But sometimes it does answer a lot of important questions, especially for that younger patient who's a little bit more complicated and their family really wants to know the exact thing going on with them. Sometimes it can be helpful to find those specific areas of cognition. So, other things that we test for, these are things to rule out. You got to look for depression and anxiety. We already kind of talked about that a little bit, but they mimic dementia in a lot of older adults. Somebody who's depressed might not be bathing very well or eating very well or doing all the things they used to do. And that's something to tease out with that history. That's what's really important. Medical history is really important. Of course, good health is good brain health in many cases. So if somebody has like really bad heart disease, multiple strokes, all these other health history, that might then affect, how we look at their dementia and what's going on with them. I put delirium on there because unfortunately very few older adults know what a delirium is, even though if you go to the hospital, it's about 40 to 50% likely you will get it. Everybody knows from probably talking to somebody at church or something, oh yeah, she went for that surgery and then she came out and she was out of it. She wasn't sleeping, she wasn't eating, she was pulling out her IV. Everybody's seen that, but that's an acute change in the brain. And we still don't understand all the reasons for a delirium, but the idea with the delirium is that it gets a little bit better, hopefully back to baseline, over time. And hopefully it happens quickly, but from speaking and working in nursing facilities where they take people after hospitalization, not as quick as family and nurses wish it would. Because sometimes it takes months to truly get back to your baseline after, let's say you go to the ICU after, whatever happens to a stroke. It might take months for you to really get back to your cognitive baseline. And this is why I try really hard. I've instructed my staff not to schedule somebody for 6 to 8 weeks after a hospitalization because I know I'm not going to get a good picture on them. I might still do a history and take, these things, but I'll probably hold off on that cognitive test because I know at least their attention and focus is going to be off, if not a bunch of other things. So that's an important thing to rule out. Medications. I could do a whole hour about medications, but I'm not going to. Just understand that a lot of medications can negatively impact cognition. These things were tested in younger people, not in you. So there are cognitive effects, there's side effects, there's other things. Doesn't mean you don't need something, and certainly do work with your doctor, but just understand that medications can have an impact on cognition, as we all kind of intuitively understand. Then laboratory testing, very important to rule out those like low-hanging fruit. If somebody has a B12 deficiency, it's like, all right, I got something I can treat and get better here. But other things, folate, thyroid, iron, all these things that we typically test for. There's a lot of talk about whether we need to be testing for heavy metal exposure. Because, Lord knows we live in, near Alcoa. There's a lot of aluminum exposure there. We live near Oak Ridge. There's a lot of, Lord knows what at Oak Ridge. And I've talked to people that said, oh yeah, and they used to dump it on the street, and this sort of stuff. So there's a lot of environmental exposures out there. We're not to where we test regularly for like lead and things like that, because the idea is, what would we do differently? Unless somebody was acutely exposed to it, meaning like they just went and took a bath in it or something, there's not really treatment. This is just cumulative damage over time. It might have been 30 years of them being a welder. I've seen a lot of welders, okay? Or other professions where you're exposed to heavy metals and toxins. It might be an acute change. Oh, I got this hip implant, and it might have contained cadmium or something, and then you wonder, okay, or cobalt, or one of these minerals, and then you wonder, okay, do I need to test for this? But I just wanted to mention that. And then of course we have brain imaging. Tried and true is MRI. It shows the structure of the brain but not the function. I get that question a lot. Now there is a functional PET scan they can do. They are very pricey. They're not always helpful. Again, we would order it if we needed to, but maybe we don't. And the specialized scans, we are very fortunate. We live near Knoxville, where they do have they do have an imaging place that does do the amyloid PET scans. They are extremely pricey though. If I told you how much, your hair would curl. All right. So blood-based biomarker testing. And by the way, Medicare does cover it, but it's still an expensive thing. So this is the new ground, the new exciting stuff that's come out in the last few years. I myself, for about the last year and a half, have been ordering these blood-based biomarkers in the clinic. Again, this is only currently recommended for somebody with actual symptoms, but we're hoping maybe the next 5-10 years, who knows, we might have a preclinical test where it's like, okay, you're turning 65, you're going on Medicare, every 3 to 5 years or whatever, we will test these. That might be something that's useful down the road. Right now they're still expensive, not too bad, but still there is some out of pocket. And so, we're not at that point where as a society we're just ordering it for everybody. But when we have a question about Alzheimer's versus not Alzheimer's, because that's all that we're looking for with this, it's a really good option. We can order through the blood now, which was, I go to these medical conferences, and for years it was kind of hushed tones like, hey, when are we going to get a blood test? Come on, I mean, when are we going to be able to detect this through the blood? And for a while there, it was only through spinal fluid. And I don't know about you, but I'm not going to subject everybody to a spinal tap, a lumbar puncture. I think that's kind of invasive for most people. But a blood test, that's something that's doable for a lot of people. And thankfully, the science has really supported that these are not only indicative of an Alzheimer's, but sometimes predictive. We're still working on that science and the recommendations. I read one study, it's like 3 to 4 years out, they can sometimes predict an Alzheimer's. But just because it's negative doesn't mean you don't have dementia. And that's an important thing to understand. It just means you don't have an Alzheimer's type dementia, okay? It's pretty good at that. You can row it in or row it out. And that's kind of what we use these for. So we actually do order these in our clinic pretty regularly. The phosphorylated tau 217, you don't have to remember that or anything. It's the highest accuracy. We usually use it in combination with that beta amyloid, the 42-40 ratio. So it's really exciting that we have these. So with cognitive testing, Part of the reason that I do my own testing, and I'm pretty insistent on this, because a lot of people do kind of let nurses and others do these tests, is because I like to see somebody do it. I like to see how their brain works and how they're working through problems. And this is kind of what you see. I will say, I think the days of a clock drawing are probably numbered. Oh, no pun intended, I didn't mean that. But in the next 10, 20 years, probably, my generation is just going to be, I don't know how to draw a clock. But I'll say it still is a useful test, especially when you're tracking it over time. And this might be what you see. I would say severe, I wouldn't even expect them to draw that circle very well. I've had a lot of people that just are incapable. They might draw a little squiggle and they're unable to do that. So, all right. So what does dementia look like for a fine artist? This is another kind of fun thing. So this is a different way of demonstrating what I just showed you with the clocks. This was, I forget where he was from. I want to say Holland. He was a fine artist, and this is before he got dementia in 1967. I'm sure his skills probably improved through that, over time. But he got his dementia diagnosis in 1995, and then you see the progression over time as his skills deteriorated. What I like is that they're self-portraits, so I think that's really beautiful, that this is also how he kind of saw himself. Clearly, there's a degradation of his ability to, kind of understand the image. What I think is interesting is he still kind of maintained the shape of the face, which is really kind of a beautiful thing. That must have been something he learned very early in art school, was how to draw that oval shape there. But I thought that was beautiful and wanted to share it. So how we stage, and this is very, very important, every person with a dementia deserves to be staged with a dementia. I can't be insistent about that enough. I wish my friends and colleagues recognize that. There are so many people that I talk to where they say, well, I don't know what stage he is. They never told us. They just said he had dementia. And I'm like, well, that's really important, because you would not. So I read a really good op-ed just last week in JAMA, the Journal of the American Medical Association. It was from a physician of over 40 years whose wife has been struggling with the dementia. She's now at stage 6. And he wrote this opinion piece because he found that people are still coming in there and asking her questions and expecting her to answer them. They took no consideration into the fact that she was in that moderately severe stage and was living in the moment, basically. They're asking her, so, oh yeah, the seizure that you had, when, and they're asking her all these questions, very well-meaning. But his hypothesis, or his, what he proposed was, we need to treat it like pediatric stages of development. So just like a 5-year-old, I got a 5-year-old at home and I have a 1-year-old at home. I don't expect either of them to be on the same level developmentally. And similarly, why would we expect somebody with dementia to be at that same level? Now, this does not mean that they're not deserving of every bit of respect and dignity for who they are, and we need to talk to them like adults, because I hate baby talk when I hear it at a nursing facility, and I really emphasize that whenever I do training. But I'll say that we still need to guide what we're saying and how we're saying it by where they are with their disease. We cannot expect for them to be at the same level as they used to. I've had lots of great spouses that said, I knew how to talk to him after 40 years, and now I don't. I don't know how to talk to him anymore. And I said, well, yeah, we have to learn that, don't we? We have to change how you speak to him, because it's not going to be the same as it was for 40 years. He might be living in this domain where he has maybe 10 to 30 seconds of active memory. You can't say, hey, honey, go to the garage, get that thing off the top shelf, bring it back here, and then we're going to... No, that's not going to work out. It might be, honey, sit down, okay, now do this. It might be a one-step command, and that's something that's very hard, especially for spouses, because there's a special relationship there that's so difficult. So just keep that in mind. So we stage dementia using, well, there's many ways of staging. You'll see all kinds of staging tools out there, but this is the one that Medicare uses, and that's why I wanted to include it. So you see how it starts out normal aging. Hey, congratulations, you're all on the scale. You're all 1 at least, but then you see how it kind of progresses from there. What I like pointing to is the mental age. Now again, this doesn't mean that the person's not deserving of dignity and respect and all these things for their learned experience over many years, but it does change how their brain is able to process and use things, and that's something very, very important to understand. This is not entirely accurate for everybody. I get people that are like looking at it and they're following it really carefully, and they're like, well, his hygiene got worse before his dressing. What does that mean? Or his bathing has changed before his, whatever. And not everybody's going to follow that exactly. These are just kind of hallmark things to understand. So no deficits whatsoever at the top. Then you get to these subjective changes where the person might recognize, but nobody else does. And then you get to actual objective changes where it's like, now the wife's like, whoa, we need to get you checked out. There's something just not quite right here. And that's at that mild cognitive impairment range. They might stay there for a long period of time. And then you get down to the actual dementia, and you see how it kind of goes from there. Very important to recognize. So hospice, I know we had a hospice talk not too long ago. Hospice can qualify you down in that lower 6 to 7 range. That's really where we might be talking about a lower life expectancy and things when somebody loses their ability to speak. If you notice, like I said, the last thing to go is the movement, is the physical ability. That's typically true. Now, there might be other reasons that somebody loses the ability to walk, like a stroke or they fell and broke a hip or whatnot. But from a dementia, that's usually a later stage thing. And so not everybody's going to follow this perfectly, but just understand stages. It's not going to be the same throughout, okay? So mild, moderate, and severe. I'm not going to go over these points because I do want to have plenty of time for question and answers and all that. But just understand that there's different hallmarks of every stage. Mild, typically these instrumental activities, driving, medicines. Then you get to moderate, and suddenly it's like, there's behavioral things, conversational things, their ability to actually care for themselves, dressing, bathing, all those things. And then you get to the severe, and really now we're trying to keep them safe. That's really the focus at severe. This person's living very much in the moment, and we're just trying to keep them from getting infections and things that would then take their life. The number one cause is typically pneumonias from swallowing, if you live long enough with the dementia. All right, so the hardest stage is the moderate stage, in my opinion. This is purely my opinion, because that's where it's a very dynamic change. Suddenly that person is very different. They have a lot of behavioral changes and other things, sometimes wandering, because again, they're still mobile. They just don't know where they're going, perhaps. And then some other things, they might be unsafe to be left alone at that point, so then it requires the caregiver to step in and to provide that extra level of support. So that's why I put this quote from Viktor Frankl about you can't really change the person, but you're going to try to change the environment, their support. You're going to get with Teresa O'Mary and others, and hopefully get a lot of resources in the home, because it really will take resources in the home to keep them out of a facility, okay? All right, so risk factors. Again, I could talk a lot more about these things. What I want to emphasize is that genetics is not everything, okay? I've had so many people that say, well, my mother had dementia, so I think I'm going to get it too. It might be 10%, 10 to 20%, somewhere in there. It's really not a huge, now there's a lot of concerns there. When you're in your 60s and getting it, yeah, that's probably very genetic. But if you're in your 80s, maybe it's something else. There's not a whole lot of genetic there. And clearly the modifiable risk factors are with, the things that you can control. Good health is good brain health, and I really want to emphasize that. All right, so proper diagnosis is crucial. Unfortunately, I've gotten several patients that were told in the hospital that they have a dementia, no history prior to that, and you're like, well, no, you're just delirious, or these sorts of things. So make sure that you're properly diagnosed as soon as possible. I cannot emphasize that enough. Once you lose brain function, you do not get it back, unfortunately. And that's just a sad reality of it. These are dead brain cells. And then, of course, all these things are important: healthy living, planning. I know we've done whole lectures on that. All right, I just wanted to spend a little bit of time, because I get lots of questions. This is don't worry, we're almost done here. About the medications. Just so you know, my grandmother was on these 2 classes of medications, and she's been gone 11 years now. So you know, these have been out a long time. They kind of slow the process down, but again, they are not cures. They're generally well tolerated. They're oral medications, so we try them, you know. Even off-label and mild cognitive impairment, especially if somebody has the Alzheimer's findings, we will then start medication, because why not? Let's slow this down as much as possible and give that person a good quality of life. So the new kids on the block here, so these are a whole different story, and I could give a whole lecture on them. Just understand that there are some new medications out. They are infusion medications. They have not had any head-to-head studies, so they're both hopefully equally as efficacious, but there are some differences in how they're given. I will say we have these available locally, thankfully, as far as the infusion centers, but you do have to go get an IV, you know, once a month or every 2 weeks, and it is a little bit difficult, but they actually do seek to treat that amyloid plaque. So they're really good at busting up that amyloid plaque. What that means for long-term cognition, we're not sure, but at least they're mostly, you know, they show benefit over placebo over time. We're 3 years out. We got data showing, yes, it still is helpful. What that means for you as an individual, we are not sure. And that's what I keep asking these people all the time is, when are we going to get, you know, this data back about whether it actually, you know, benefits them or not? And there probably are better options on the horizon. They will, of course, be ridiculously expensive starting out. But there are some drugs in the works. We're finding new targets regularly, and we're trying. There's a lot of trials out. Like I said, this is a problem, and we want to treat it. You know, it's going to take time to get that science there. So, lastly, here, this quote I included last year because it came out right for my last talk last year. Dementia is getting more common, and some of that is because we're testing for it more, and we're not just treating it like normal aging, but just understand that there's an imperative, there's a societal need to take care of these people, and we shouldn't just assume that there's enough beds in nursing homes or these sorts of things to take care of their needs. In fact, when I talk to my patients, that's typically the last option that they have. It might be the most appropriate one for them, but everybody wants to live in their home, be independent, and die on their own, you know, in their own bed. And I think that that is a reality for a lot of people. I hope it will be more common than just expecting everybody will need a nursing facility. But just understand there is an imperative there to treat this. So, all right, woo! All right, I talked for a long time there. Thank you.